Go ahead.
Well, good morning, everybody. My name is Paul. Looks like we're going to get started. And see, we got the slides.
Well, let's open it up, see if anyone has any questions or cases that they want to talk about first. Nikki, did you want to talk about the case that you brought up at the MAT clinic?
No, I think I'm good just now. I don't want to, let me see how I do, because I'm trying one of the things that they suggested. And so we're going to see how that goes. Just the diversional stuff, instead of spending all day concentrating on the pain, to spend more time doing thinking, like a hobby or walking or something other than things. And she's willing to buy into that. And so we're thinking of different things she can do rather than sit there all day thinking about how much pain she's in. Okay. So that's what we're trying right now.
That's great. All right. Good. Perfect. Keep us updated on that one then, definitely.
So exploring things with healthy distractions.
Yep. Yep. Oops. Nikki, can you hear us?
Yes, sorry, what?
To exploring options with healthy distractions.
That's what she was doing, yeah.
Okay.
Yeah.
Okay, good. And there's Dr. Patterson. Good. Sorry, guys.
Good morning.
Sorry, we're having some audio issues here. Let's see, so we'll start off. So who do we have today?
Becky, do you want to start us off?
Hi, Becky Bailey with Nevada Rural Hospital Partners.
Hi, Becky.
And then we'll go to the Ely Hospital, William B. Ryrie. Who do we have there this morning?
I'm Rocky Jones, nurse practitioner.
Norm Christensen. Greg Tanner, OBGYN.
Great, good morning.
Nice to have you.
And Nikki, do you want to just introduce yourself real quick?
Nikki Bain with Nevada Health Center in Austin, Nevada.
Alrighty. And do we have anybody at RSIC this morning? Rena Sparks, Tribal Health.
Well, there's our medical director.
Wonderful.
Good to have you. It's Dr. Harrison.
And Maurice. Could you take yourself off mute? It's just the icon in the lower left corner of the Zoom window. Marie, can you hear us?
Maybe not. She hears.
Okay, and then Keela Patterson, could you introduce yourself?
Hi, can you hear me okay?
Yep.
Hi, so I am a second-year grad student at the University of Hawaii at Manoa, and yeah, I'm just attending this as I'm interning with a psychologist who just took over the pain management department at our health clinic, so I'm interested to see, yeah.
Great to have you, thanks.
Welcome.
And Anne, could you introduce yourself and tell us where you are and that kind of thing?
I'm Ann Miles. I'm a PA out here in the frontiers of Nevada in Kingston Health Center.
Welcome.
Good to have you.
Thanks.
And then Dee Peterson. Maybe don't have audio there, I don't think. So I'll send you a chat though. Alrighty. If there's no cases or questions anyone wants to talk about, I think we'll move right into the presentation then. Anything out there? Ely Hospital? Any cases you want to talk about?
Nope, nothing here.
Nothing? Great. Okay. So,
All right, here we go. Well, on my right is Dr. Patterson. He is a pain specialist, physician, And on my left is Dr. Mike Lewandowski. He is a clinical psychologist, also specializing in pain. And I am a substance use specialist working with mental health, pain, just about the whole package that comes with opioid treatment. So I have a master's degree from Hazelden Graduate School of Addiction Studies. And what does that mean? That means all we did was think about and talk about what goes into addiction. And after my master's degree, it came down to really getting the person to stop using substances was about 3% of what we do. That's called detox. The rest of the time that we work with people has to deal with the way that the addiction strikes. First, addiction usually strikes spiritually. Now, don't get upset when I say spiritual. That's your own conception of your higher power. That's not pushing any kind of religion or anything, no hidden agenda there. Then it hits emotionally, then it hits mentally, then it hits physically. So when it hits physically, many people say, hey, you know what, this person has a problem, this is uncomfortable to look at, we have to get this person fixed. And so they send them to somebody like me or one of the specialists here and say, hey, get this person right. So the way the addiction strikes, the exact opposite is the healing process. First, it starts physically. That's detox. It takes a short amount of time. Then it goes mentally. That takes a little bit longer time. That's usually a few weeks before, but then the person starts to remember what happened the week before and the day before, and they start getting their relationships back because they can remember who they are. Then we spend a majority of our time on the emotional issues. So the way it comes in, the exact opposite is the way that it's healed. So why does it matter if there's residential, intensive outpatient, outpatient, individual, or groups? These are all different levels of care. What's the big deal there? The big deal is figuring out what's the appropriate level of care for the time the person needs it. So residential, I'll take you through a quick walk here. Residential, that's 28 days, 4 weeks, and that's usually dictated by the insurance company. Residential can go months, it can even go years, but that's 24-hour monitoring and structure, and that's to help that person get into a healthy kind of environment. Then we have intensive outpatient. Intensive outpatient is 3 sessions a week, 3-hour sessions with individual counseling and a family component. And the reason there is you're stepping down, you're going from 24-hour monitoring and structure into an intensive outpatient group setting where the person can test out all the stuff, all the coping skills, all the things that they have learned from residential and actually try it out in the environment that they're put back into that hasn't changed a bit, even though they're trying to change everything. Then after about 3 months of intensive outpatient group therapy, then they move to outpatient. That's 2 sessions a week, 3-hour sessions with the individual and family component. Family component is really important because it helps the person stay accountable and it helps make it a group effort because, hey, as brilliant as we are, we'd like to say the magic words in 1 hour or 7 minutes or however much time we have with the person. The family gets to spend their whole life with them. So they also have some skin in the game. So then it goes down to individual cases and then it can go into groups. AA can be throughout this whole thing, Alcoholics Anonymous or Narcotics Anonymous or Gambling Anonymous, whatever. That can be throughout the whole system. Some people think that AA is the whole reason that they stayed sober. Some people think that it doesn't have any bearing at all. Some people grow into it, some people grow away from it. But it's putting up all different kinds of things, and at the correct time, it might be appropriate for that person's treatment or care. So, long story longer, let's discuss cases. Troy already took care of that. You know, and by the way, we really have to thank Troy and Chris and Austin and all the people who make this possible. These are the silent warriors behind here who make all the technology and everything available for us at ECHO. So I really appreciate your teamwork. Thank you very much, Troy. All right, so today we're going to review the need and benefits of screening for substance use and or mental health disorders when considering treatment. You've all heard of screening tools. We'll go through some screening tools, but the big question is why? And will it benefit my patients? And how do I fit this into my office practice when we're already overloaded right now? So will it pay off? Will this time in the beginning pay off in the end? It has to make sense. Identify co-occurring medical issues which are caused or impacted by mental health or substance use issues. Because folks, when they come to me, it's a package deal. The mental health and the substance use, they go hand in hand. If I have one, I'm going to have the other generally. Discuss strategies to implement screening assessment tools efficiently while honoring the physician's time. Examine different options of screening assessment tools available. So we're in an overdose crisis. 12-month ending number of overdose drug deaths. Well, that's a lot. Comes to about 72,000 deaths per year now for overdoses. When I see something like that, I think 72,000, that's a whole bunch. You know, I was listening to the news today and Amazon reached $1 trillion. That's a whole bunch. Okay, trillion. So that's 1,000 billion. Well, billion's a whole bunch. What's a billion? 1,000 million. Well, 1,000 million, that's a whole bunch. All right, so these numbers are outrageous. How do we bring them into focus and say, you know what, there's people behind these numbers. I hear 72,000, I see that it's going up. I don't know what that means. So I have to make it bite-sized. It's like eating an elephant. How do you eat an elephant? One bite at a time. So I have to break it down. So that's almost 200 people every day last year died from a drug overdose. 200 people. How many people can you fit in a jetliner? Now, if a plane was going down every single day in the United States, we'd say, hey, there's a problem.
Yeah.
Okay, maybe we should look at the engines, or maybe we should look at the wings, or maybe we should look at, 200 people every day. So my wife and I were going up to the Vietnam Memorial up in Carson City, and we saw all those people. There's just names. I don't know if you went out there, but you see all of those names. So you go up and you touch the names and you kind of relate to some, or try to relate to some of them, say a prayer, that kind of thing. And then I'm thinking, 58,000 people died in that war. We have 72,000 that are dying from overdose every year. So I'm comparing it. And I think, what's 58,000? Well, I'm in Carson City, so I look up the population of Carson City. We're over the population of Carson City. That's 54,000 people. So I threw in Wingfield Springs, because we were there that's another 15. We're still not there yet.
Yeah.
Sparks is 92,000. So what do we have to do to either build this up or start taking it down now? We have the 72,000. It needs to come down now. So how do we do that? One of the ways we're going to be talking about is screening. So this is 2015, and I don't think the numbers have gotten much better. 27 million people reported current use of illegal drugs or abuse of prescription drugs. Despite this self-reporting, only 10% of the nearly 21 million citizens with substance use disorders received any type of specialty treatment, according to the National Survey on Drug Use and Health. This is contributing greatly to the increase of deaths from overdose. 40% of the people with substance use disorder also have a mental health problem. I think that's a little bit light. But less than half of these people receive treatment on either issue. Here's mental health and substance use disorders in the United States. That's the leading cause of disease burden in the US. That's ahead of cancer and tumors, cardiovascular disease, injuries, musculoskeletal. If you put the overdose deaths together, that's more than car accidents and gunshots combined. You look at mental health and substance use disorders, that's more than any of these other disease states. So, it's a pretty big deal. So how do we identify possible substance use disorders and or mental health disorders? And why would we do this? The upfront will pay off substantially in the physician's time. Distress for the physician, the physician's office, and the patient's family, and money. It creates a synergy between the primary and secondary healthcare services. Physicians, you're not alone. There's support out there. You don't have to be isolated. You don't have to take on all this responsibility. You don't necessarily have to have all the correct answers all the time. You can reach out for support. You don't have to be 100% the only person who's taking on all of the liability. This is the idea of ECHO, this is the idea of sharing, this is the idea of staffing, this is the idea of bringing on specialists to help with all of the stresses and pressures and things that you have to go through. You're recognized, you're appreciated, and you're not alone. Screening and assessment tools, this is what Troy and I were talking about earlier, may be used to help nurses identify significant uncovered risks and problems with drug and alcohol use, and paraprofessionals can administer and score the screening tools. So the screening tool isn't necessarily just to say what the person has, it's to give you a flavor, it's to give you an idea of what you're getting into with this person. One of the most important things that I try to do with my screening tools is rule out things. So I want to rule out comorbid, acute, or chronic pain disorders and opioid dependence. I want to rule out polysubstance use, rule out co-occurring psychiatric disorders. Mental health screening form 3 is an easy way to do that. I'll show that one to you. Screen for infectious diseases, screen for domestic violence, abuse, and or trauma. If you've heard of the ACEs tool, that is an incredible way of figuring out where the trauma lies. Because a lot of times with the patients that I'm honored with serving, it's not if they have trauma, it's the level of trauma that I'm going to be working with. When I'm looking at substance or medication induced disorders. Okay, well, somebody comes to me and they're coming down, or maybe they're still on some meth. Yeah, they have anxiety disorder, or what presents as anxiety disorder. We get that meth out of their system and all of a sudden the anxiety goes down substantially. Bipolar and related disorder. Okay, so the person comes in, they're feeling blue. They're not motivated. They have some insomnia and they're feeling a little bit anxious. What happens? Oh, if we give them an antidepressant and they're bipolar, guess what? We just triggered that manic phase. When they're in the manic phase, they're not going to see the physician. They're at the casino spending all their life savings or going at the car dealership buying 3 of the same cars. Then they're feeling that incomprehensible demoralization after they're coming down with that dopamine that's been depleted. Then they come back in and they see me and we have depressive order? No. What we have is we have the swing of the substance that's coming in and going out of their system. Major or mild neurocognitive disorder. If you've seen anybody really on any substance that is at a substantial amount, you have mild or major neurocognitive disorder. obsessive compulsive or related disorder. This one reminds me so much of alcohol. They're in the bar, alcohol's taken over, prefrontal cortex has been disabled, ventral tegmental areas going to the nucleus accumbens. This sounds like a good idea. Throwing out that dopamine. All of a sudden, you get those two guys looking across. You're choosing me off. We're gonna fight, right? So either that or I love you, man. That pendulum swings either way. That's why you don't see a lot of fights in bakeries. So the obsessive compulsive disorder, it's what's going on in that person's system with those substances that they're putting in there. Psychotic disorder, yes. Sexual dysfunction, well, you have somebody on morphine in the form of heroin or alcohol or any kind of sedative. You're going to have sexual dysfunction. You put them on a stimulant, you're also going to have sexual dysfunction, just going the other way. Sleep disorder, this is one of the biggest deals that we have to look after, folks. This is so undiagnosed. I think Dr. Lewandowski and I, we're going to be talking about this in a few weeks. But sleep disorder and Dr. Patterson, this is a big deal. We have to look at people's sleep. This is an activity that they're going to spend a third of their life doing. And many times people don't realize if they've had a good night's sleep or a bad night's sleep. And there's no real way to tell unless they're taping themselves, and that'd be kind of weird. But we have to look at sleep. So who's suffering from a substance use disorder? Yeah, y'all picked out that little kid. No. You don't know.
The Hulk.
Yeah. They come in all different shapes and sizes, all different professions. You have no idea when the person's presenting. So we screen universally because we don't know who's being impacted by substances or by what level. So drinking and drug use, we'll go into that, and we'll go into a little bit of mental health. So drinking and drug use is common. Often go undetected, can increase risk to safety and health problems. Now think about this. I'm talking to my mother-in-law, and she's talking about colonoscopy that she has to take in 3 years. That somehow or another, that has resonated. That kind of procedure has set. And people say, yeah, okay. So we screen for other potential medical problems, cancer, diabetes, hypertension. As soon as they go in, we're doing the vital signs, except for the 5th vital sign. We've all talked about that. But why not for mental health and alcohol and drug use? If it's there, if it's prevalent, if it's leading to this problem, why aren't we taking that extra time to screen for these diseases? We want to detect the current health problems related to at-risk alcohol and drug use. Now, if somebody drinks a beer, they're not going to be an alcoholic. If somebody takes pain medication, they're not going to be addicted. Actually, a vast majority of the people are not. However, that 72,000, that number is real and it's growing. Those are the people that we're trying to recognize that maybe we need to get them some more help. So we want to detect alcohol and drug use patterns that can increase risk of future injury and illness, provide early intervention and or referral to the appropriate level of care, we talked about that, and prevent medical and prescribing errors. Now, when we're talking about the vast majority of people, a vast majority of the people, 71%, I think that's a little bit low, I think it's a little bit higher. A vast majority of the people are going to respect the white coat that you have earned. They're going to recognize all of the education, all of the pain that you went through to get that designation of doctor or healthcare provider. And they're going to do exactly what you say, and they're going to give you the respect that you deserve. Now, 25% are going to fall into some kind of harmful or risky use kind of category. And this could be intentional or unintentional. This can be a lifestyle, this can be an environment, this can be all kinds of different reasons, and this can be just determined to abuse the substance. Then we have the cap here, about 4%, which is dependent use. So I think that one's a little bit low too. But it gives you a good ballpark of where people are. So brief intervention and referral to treatment. Now here's the interesting thing. Take this pyramid and flip it upside down. That 4% are going to cause you a majority of your time, effort, energy, stress. They're going to be a drain on your staff. They're going to be a drain on your office. This 4% or 5%, this small percent, is going to be the ones that you want to get to the appropriate level of care, because if they're on that hamster wheel just getting substances and moving through, we're promoting that 72,000, we're promoting that lifestyle, we're promoting that message. So this is really the group that you're wanting to refer to the appropriate level of care, and then you want to see them back. That's why you want to build the team. You don't want to abandon, you don't want to just hand them off, tee them off. You want to take care of them with all of the brilliant things that you have to offer. But get those guys into the appropriate level of care through the network or the referrals that you can use. Medical settings, a great place for screening and intervention. When you put on that white coat, if I go to you, I'm looking for truth. I'm looking for what's going on. What do you see, doctor? How can you help me with my cholesterol? I can't see cholesterol. I can't feel it. I trust you. I trust all the things that you stand for. And that's why I build a relationship with you. And that's why I keep coming back. I am your patient. So when the physician tells me, hey, you know what? You might have an issue here. I'm listening because I'm coming to that person. As soon as I sit down and you're sitting behind that desk or you're scooting up to me in those roller chairs, you have all my attention. So alcohol and drug use contributes to injury and illness. Okay, how did you fall down? How did you break your fibula? How did you hurt your leg? How did you hurt your... Well, I was drinking. Okay, red flag. Alcohol and illicit drugs interact with prescribed medication. Okay, so you're taking your benzo and you're taking your oxy for your pain. You're taking your benzo for your anxiety and to help you sleep. And you're drinking your whiskey before you go to bed, maybe not the best idea. Or we'll throw in soma. So now we have the trifecta. Maybe not a good idea. Where did you get the benzos? Oh, your wife has them because she's feeling a little bit nervous and you're starting to feel a little bit nervous. Not a good idea. Alcohol and drug use affects families and communities. It's a ripple effect. Early intervention may reduce health consequences and save healthcare dollars. This is what I was talking about. Patients are open to discussing their substance use to help their health. If my doctor asks me how much I drink, I would give them an honest answer. 92% say yes. This is the opportunity, this is the time to ask them these questions. If my drinking is affecting my health, my doctor should advise me to cut down on alcohol. 96% yes. 93% yes to as part of my medical care. My doctor should feel free to ask me how much alcohol I drink. This goes for substances too, all substances. You want to know as a scientist, as a researcher, as a physician, what is in that person's body? What's in their respiratory system? What's in their GI tract? What is impacting their brain and their body, which we now know are connected. I would be annoyed if my doctor asked me how much alcohol I would drink. 86 say no, they disagree with that. I would be embarrassed if my doctor asked me how much alcohol I drink. Almost 80% say they disagree with that. So when we're looking at drug screens, does anybody have any comments or questions? I'm kind of going. No.
Well, I'd be curious to ask Dr. Pettis the question. Do you feel like you get honest answers from your patients if you ask those questions? As a pain physician?
You know, what's interesting is especially the alcohol use and pain medications. A lot of people get angry about that, and they feel like it's none of, that it's legal and they can do what they want and it's none of my business. And I try to explain to them, well, it is my business, because if I'm giving you substances that could potentially, combination can kill you, then I need to know what's in your system. But, I would say a lot of people get angry over that.
Interesting, yeah.
Like, they don't want me to test for that. They don't want me to know that they're drinking alcohol.
With my primary care physician, if my primary care physician doesn't ask me that stuff, I get upset. I want you to know what you're dealing with here, doctor.
Yeah.
Now, you're a specialist.
Yeah.
Okay, so how many primary care physicians do we have?
Show of hands.
Okay.
Yeah, there you go.
And then Anna's one.
Uh-huh. Yeah. How many in their cocktail, how many opioids, or how many people usually have opioids when they're coming to see you?
Me?
Yeah.
100% probably. Well, I take it 90.
90%. Okay. So we kind of look at that, and I think they've heard the messages that opioids are bad. We're going to try to wean off of opioids, and other they've heard it from other people. The pendulum is swung.
Yeah. And
so we look at it, like where.
But I do hear the other side of it. I hear is, doc. One, I've been on these for years. The benzos, the alcohol,
It's okay.
and my body can tolerate it. Like I'm not gonna kill myself. One that's short-sighted on their behalf, right?
Yeah.
Two, I also hear, doc, you're too strict. I'm just gonna go back to my primary care because they're not checking for these things.
Good Lord. Anybody else hear that or relate to that?
Interesting. So
It happens all the time.
So maybe the level of specialty, primary care versus the specialty care.
Yeah, I mean, they see the lower fruit being the primary care that they can get them with no, they're just going to prescribe to them and they're not going to check what they're on, or
Perhaps, yeah.
there's not as much screening. It's kind of my impression.
Well, and you don't need a prescription to get alcohol either.
No.
They need your permission to get a medication of some kind.
Correct.
Such a good point. When I'm seeing somebody who's been on Oxy for 10 years or benzos for 20 years, and and they decide that they want to come off of it, 2 decades.
Yeah.
They have been trained. That behavior is in there. Benzo withdrawal can last for months.
Yeah.
And when they're going through the withdrawal, there is a quick relief that is already available, that they've been trained to use, that they know is just a one pill away for complete relief. And it takes a long time to get through that payoff if they're going to go for function as opposed to pain relief. But then again, we're not demonizing opioids either.
Yeah.
There's a good reason for it. So absolutely, I hear you.
Yeah.
I hear it. Yeah. One of the things that we use as a tool is drug screens. Drug screens are done for the patient, not to the patient. So it's not a gotcha. It's helping the physician understand what's in that person's system. It's 2 purposes. Discover if the compounds are present that should not be. Like, what else are you supplementing this with? I had one lady who completely stopped her benzos. Completely. But how did you do that?
Yeah.
She was drinking a bottle and a half of wine before she went to bed. So we want to make sure that we understand exactly what's in that person's system. Confirm that compounds are present that should be. So the person comes in and they're getting their 30 Vicodin every month or 60 Vicodin every month. And they've been doing that for the last 6 months, a year. And you do a drug screen and you find out there's no opioids in their system. So we want to make sure that things are there that are supposed to be.
if I can go back to that, I like what you said about it's for the patient. You know, it feels like you've been talking about trying to stratify risk. Who's the riskiest? But you want to give that information to the patient.
Yeah.
Just say, hey, you know, you're in this high risk category. So we may need to want to look at these things. So it's really for the patient, not to them.
Love how you put that.
Yeah. So
really nice.
Yeah.
Yeah, this puts you into a high risk. How can we help you out of that high risk category?
Yeah.
We might add somebody to our team to look at this specific area and then bring you back in. Making the patient accountable.
Yeah.
So drug screen interpretation, most drugs in urine have detection times of 1 to 3 days. Chronic use of lipid-soluble drugs, test positive for more than 1 week. If you're doing some edible medication or recreation, whatever is going on out there, that can be detected for up to 5 weeks. Drug screens do not diagnose. They can't tell you if the person has addiction problems, physical dependence, or impairment. And they don't provide enough information to determine the exposure time or the frequency of use. So here's a whole bunch of screening options. This is from SAMHSA's SBIRT, Screening, Brief Intervention, and Referral to Treatment. So we have AUDIT, that's for alcohol, that's 10 questions. We'll go over that. SOAPP and ORT, go over those real quick. DAST, it's 10 questions. Mental health screening form 3, I like that one. There's teen health screens, CRAFT and PHQ-9. Behavioral health risk, there's all kinds of screening tools available. This one's for pregnant women. I really like the ACEs and resilience and stress questionnaire. And we have the MSQS that we need to put up there. And that is, but that's a tool.
Yeah.
Okay, so we'll stick with screening. So definitions for unhealthy drinking. At least ask this question. In the last year, how many times have you had 5 or more drinks? That's for men. The last year, how many times have you had 4 or more drinks? That's for women. That if you don't have time, that one question can tell you what's going on.
And that means at one sitting, I assume, right? One occasion?
One occasion. Yeah, or over 14 drinks in a week.
In a week, okay.
Yeah, or women over 7 drinks in a week.
That's interesting too. If an ounce, you know, is considered a drink, and you have a, 2-ounce drink, that counts as 2 of those 5 drinks. I assume, right?
Well, it just starts us on the trail. It starts the conversation going.
Yeah.
It's not a diagnosis, just like a drug screen. It's not anything. It's just to say, hey, you know what? Now we're on the radar here. This could be an issue. How many in the past? So this is for real quick questions.
Yeah.
How many times in the past year have you had 5 or more drinks in a day? For women, 4 or more drinks in a day. How many times in the past year have you used a recreational drug or used a prescription medication for non-medical reasons? Boom. If that's all you have time for, okay, you started the conversation. This is the audit developed by the World Health Organization. It's relatively accurate. Scores of 8+ indicate risky drinking. Scores of 20+ may indicate need for treatment. It's even a little bit lower for the risky treatment. These are the questions. I thought it was kind of hard to read them.
Yeah.
So I just typed out the questions. You can ask a few of these questions, like the CAGE test is only 4 questions. Has anybody ever asked you to cut down or stop drinking, or has anybody annoyed you? Have you ever wanted to have an eye-opener? Have you felt guilty about your drinking? That's the CAGE screening, those 4 questions. And you can see them all in here.
For the one I found, there's no data behind it, but I just asked people, do you think you're an average drinker? And I leave average out there.
I like that.
And I'll say, would you maybe have a hangover after the Super Bowl? Would an average drinker have that? Well, maybe. But you know, an average drinker may not vomit 5 times a week after they drink, right?
Yeah.
Or, you know, so trying to get them to define average also is, I think, interesting because it engages them in the process.
Right.
Perfect.
Yeah.
Does anybody use any screening tools like this, or the cage, or is it part of your regular initial interview with the patient? What do you use? Ely.
Nobody wants to.
I know. Well, I just threw it out there. I'm throwing it out a wide net.
I think Margaret was shaking her head.
Oh, Margaret. Yeah. Sorry. Yeah, there you go. Hi.
I just direct.
I want to say we have the cage as part of our screening, but we also go into more detail with specific questions about their use of alcohol or any substance.
Do you find the cage effective?
Yeah, it gives me a good initial quick look as to determine if I need to focus more on substance use.
Perfect. Good. How about for drugs? How about for substances?
I use the ORT and sometimes the SOAPP if needed.
Okay. Good.
And I think we missed what you were saying there, William B. Ryrie.
I just directly ask. I mean, I use the work for the narcotics, but other than that, I just ask my questions and then kind of delve from there.
What questions do you find effective?
I just kind of, I try to build that relationship. So I'm just direct, even as a new patient, how much you drinking. And again, your inversion of the 4%, 25, 71% or whatever the triangle was is pretty much, if you add up your numbers, for the response on your questionnaire of how honest are you with alcohol consumption, 92%. Well, that's kind of what your upside down triangle is, right?
Yep.
Got that huge percentage, it still doesn't tell you, that 4 or 5, up to 10%. So you got to kind of just talk to them and just kind of read between the lines on their body. Body language tells a lot when you start asking some of these questions. They start to fidget, they're not telling you the truth.
There you go. There you go, that alliance.
Thank you.
Thank you very much. Okay, audit scoring. This is a shorter version, like we were talking about the cage. This is a shorter version of the audit C. How often do you have a drink containing alcohol? So it's scored 0, 1, which is monthly or less, 2 to 4 times a month, to 2 to 3 times per week, 3, 4 or more times a week, 4. So 3 questions. How often do you have a drink containing alcohol? Boom. How many drinks containing alcohol do you have on a typical day when you're drinking? And how often do you have 6 or more drinks in one occasion? And so maximum score is 12. Anything greater than or equal to 4 that's above the recommended levels, and greater than 2, that's for women. That can be hazardous drinking. DAST. One of the important things is figuring out what's in the person's system and the drug use. So there's all kinds of drugs that are available out there, and just because somebody thinks they're putting something in their system doesn't necessarily mean that that something is pure. In other words, it could be mixed with a lot of different things. There's all kinds of things that can be ingested that have, the person thinks it's one thing, and actually they're getting something completely different.
I've seen that a lot with marijuana, like patients that say, well, all I'm using is marijuana, and then they test positive for meth. And so I've always wondered if they're lacing the marijuana with meth or other substances that make them test positive.
Always. You'll see a lot of that with the emergency room physicians. If somebody's been dabbing, they think the person's on meth. and it's actually all they have is THC in their system. Dabs are 95% and up THC, pure. When we're looking at, there's like meth, you want to set aside your product. And so to make it more of a speedball or upper, put meth in it. If you want to bring it down, or put some heroin in it, or morphine, it's all the same. You know, if somebody's taking it recreationally, you just don't know really what you're getting, correct? Even for the level of THC. So that's one of the reasons for the drug screens too. You want to find out what's going on. DAST questionnaire. This is for our drugs. Same kind of thing that we ask for alcohol too. Have you felt bad or guilty about drug use? Have you neglected your family because of your drug use? Now, next week I'm going to be talking about dependence. And so a lot of this stuff is in for the criteria to recognize if the person's mild, moderate, or severe, has severe substance use disorder. Here's our scoring for the DAST. Assessment and screening for opioid use disorder. Do you use this, Preston? What do you use?
We use the ORT.
Okay, this is coming up. But the reason that you assess and screen, you want to know if the person's taking other substances as well as the opioids. If they're taking opioids and they're taking another substance to supplement that opioid, then that probably isn't in the patient's best interest. The reasons for use. Why are they using this substance? Is it ongoing pain? Is it to decrease negative feelings? Is it a combination of both? Is it sleeping better? Is it anxiety? Do they have a craving for the next dose? How are they consuming the substance? Are they taking it IV, snorting, or smoking? Now, a lot of people, when they're smoking, like heroin, for example, it start with snorting, it gets them a big pop. But if you're smoking it, you're losing about 75% of the drug to the atmosphere. It's going up in smoke. The reason that you slam it is so that you can get 100%. And when you slam it, it only costs about 10 to 15 bucks a shot. And you're going to need another one in about 6 hours because it has a relatively short half-life. And that's where the cycle gets going. So I never wanted to slam, but it made economic sense and I had to do it to avoid the withdrawal. Usually when they come into the IV level, they're not really having fun. They're avoiding that withdrawal. Tolerance, need for higher amounts for the same effect. When was the last time that you used? That's a really important one. If you're presenting with all kinds of anxiety or depression and you just used recently, that could be the reason. Anytime that opioid use is interfering with life and routines, and this is where you can bring in other people, their family members. Biggest thing that I hear from family members is they want their son, daughter, spouse, they want them back. And so the substances have taken a life of their own and taken this person hostage, and they just want to break those chains, get their person back, have some laughter back in their life, have some good food, family time. Prior treatment history. If they've been in treatment before, it's like we say in the substance use world, if you get a DUI, all right, you got a DUI. If you've got a second DUI, you probably have a drinking problem. Same thing with prior treatment history. You've acknowledged it, you've been to treatment, okay. And you know what, we're not gonna condemn anybody. Relapse is one of the stages of change. We're just gonna go back and fix what needs to be fixed. Medical, psychosocial, family history. When I do the evaluation, the 2.5 hours that I spend with the person, that's for, I want their biopsychosocial, medical, environmental, their family. I want all of their information so that I can figure out where we can launch from, where we can begin. And then that's not a label. That's just the best idea that all the tests came back that said, and what I think and what the person thinks. This is where we're beginning. And you know what? This is the furthest thing from a level label, because this needs to change in a very short amount of time. And so make sure people understand, we're not labeling you as an addict or alcoholic or whatever label you're carrying around, because people carry that baggage with them and they tend to use it for all kinds of different reasons, including reasons to go back to using. Physical examination, always a physical examination. You don't know what kind of damage they've done. If you've been on meth for 4 days and you've done your bender, that person is dehydrated. They've drained just about every fluid out of their body. Can you imagine if your eyes have been open for 4 days? Your eyelashes hurt. Everything needs to be looked at. If the person's on heroin and they're coming out, everything that's been constipated by that opioid is now being released. And so there's a whole bunch of stuff that needs to be looked at there. And laboratory analysis. So there's our SOAPP. You're all probably familiar with SOAPP, Screener for Opioid Assessment for Patients with Pain. Here's our ORD. Relatively easy, quick, pretty easy to understand. Score of 3 or lower indicates low risk for future opioid use risk, 4 to 7. And these are best guesses. So we can always revisit these. Like the MSQS, we revisit that to see the growth that the person has gone through. And we'll go through that one a little bit later. COWS, Clinical Opioid Withdrawal Scale. What I like about this one is if somebody's going through withdrawal, you can build the alliance and you can really get to the bottom of it just by putting your hands out, saying, hey, how you feeling? When's the last time you used? Have them put their hands on your hands. The reason that they're doing that, they might think, oh, they're building the alliance. But what you're doing is you're checking for tremor, you're checking for sweating, you're checking, you can even check that pulse rate sometimes there. You're getting a lot of information of where that person is in their withdrawal. And then once they get to that place where you've said, okay, yeah, things are, and it's pretty easy to see somebody who's going through morphine withdrawal. Yawning, tremor, GI upset, everything's leaking, goose flesh, anxiety, irritability, it's pretty obvious. Then just by that, you can transition them into the, which is really appropriate, the emergency room, because they need to be medically monitored.
I'm just curious, the yawning, what physiological mechanism of that when somebody's withdrawing? What does the yawning do? Is it trying to get oxygen, or?
It could be, but that's no, that is, they're yawning. They're yawning 3 or 4 times.
Is it a fatigue issue, or is it?
I don't think it's fatigue, but they're yawning. They're trying to get that oxygen. I don't know what's going on, but people are yawning. Pupil size, restlessness, all of it. All of this is, you will notice it. So anything above that moderate scale, you should get them to the emergency room, because these are just things that you can observe. These aren't the things that are happening behind the scenes. And you really don't know what other substances they've taken. Many times people will take meth with their heroin because it takes off the edge of both of them. Heroin kind of takes out the edge of meth. And the reason I like, okay, better hurry up here. So we have mental health screening. Reason I like the mental health screening form 3 is because of the way that it's laid out. It's 17 questions. It goes through all kinds of different diagnosis questions, and you can get a really good idea just by seeing the yes or no, if you need to explore other areas. So they go through, like question 5 would hit schizophrenia, 6 is depressive disorder, PTSD for 7, all the way through to sexual and gender identity disorders, learning disorders, obsessive compulsive. And just by looking at this, you get a quick idea of where you might have to go in. Now, this isn't thorough. None of these are thorough. They're just screening tools. So here are the questions. After you've done screening, then we do the transition to brief intervention. Thanks so much for answering these questions. I was wondering if it would be okay if we talked a little bit more about blam. So then we talk a little bit more about whatever, and then hopefully you can transition them onto another team member and help you bring that person back.
So screening helps stratify risk, which then allows you to allocate levels of care to the different areas. It sounds like you're saying.
You just saved about an hour worth of me chatting here. Thank you. Very nice. All right, well, thank you very much. Next time we're going to be talking about
diagnosing use disorder.
Diagnosing use disorder. Thank you all very much. Have a wonderful day, wonderful week.
Thanks, everyone.